Yeah, thank you for inviting me to be able to present in favor of maintenance therapy as part of our treatment strategy for metastatic colorectal cancer. And Howard already kind of gave part of my talk, and so I can brush over some of the slides. So just to give you an idea, what are we really talking about in the palliative setting for metastatic colorectal cancer? What do we try to do? And I think the goal of palliative therapy is, and this is how I talk to my patients, is to extend the patient's life, maintain quality of life as long as possible, using the least amount of treatment necessary to control the disease. And we're quite successful doing this because we've moved overall survival in metastatic colorectal cancer quite to about 3 years median in clinical trials. And in clinical practice, all of us have patients who survive metastatic disease for 5-6 years. Now, the idea of maintenance therapy was kind of really put to the surface of our thoughts by using oxaliplatin in first-line treatment, because we could see that patients had to discontinue therapy before they even had progression of disease, even before biologics came about, which then even emphasized this problem, because we could control their tumor longer even in first-line therapy, but cumulative neurotoxicity prevented us from using treatment to progression. Now, but even before oxaliplatin, there was some data that came about in terms of, using stop-and-go and maintenance therapy regimens. But before I talk about that, I want to make one thing very clear, which I think is important when we talk about treatment strategies. When we see what happened in the last decade, first-line PFS has not changed. We're really about 10 to 11 months first-line PFS, dating back to 2004 to 2014. What has changed is overall survival. And this is mainly an effect of post-progression therapies. We just have more tools available, and maintenance therapy is part of this tool. In 2004, first-line therapy it covered about 50% of a patient's life. In 2014-15, it's about a third. We overemphasize what first-line therapy can do. We need to really talk about the strategy, the treatment strategy. That is what's really affecting patient survival. And maintenance therapy is part of it. Now, coming back to the early days, there was an MRC trial published in Lancet more than a decade ago looking at intermittent versus continuous therapy, and Tim Maughan at this point said our findings provided no clear evidence of a benefit in continuing therapy indefinitely until disease progression. That was at a time when we used chemotherapy like 5-FU-mitomycin, had no oxaliplatin, no irinotecan, and then the Optimox studies kind of put this we should not use treatment until progression a little bit in question, because we had data from Optimox 1, in particular from Optimox 2, which tested maintenance therapy versus a chemotherapy-free interval, Optimox 2, and actually showed a potential detriment for stopping treatment and not continuing some maintenance therapy. Not statistically significant for overall survival, but for PFS clearly statistically significant. And the study was never powered to show overall survival benefit. Now, I know that Dr. LaBianca, who's my counterpart, will say, you'll have a meta-analysis, continuous versus intermittent therapy, which was published just recently and showed there is no survival benefit for continued therapy. But the problem is here, all these trials that were included were very heterogeneous, including trials which actually had maintenance therapy in both arms, like the Optimox 1 study. And maintenance therapy was not rationally designed in these trials necessarily. And I'll tell you what I consider the best maintenance therapy. And key trials, the AO trial and the DREAM trial, more recent trials were not included. So what do I consider the best maintenance therapy? And I go back to the IFL plus minus bevacizumab study, which had 3 arms initially, including a fluoropyrimidine bevacizumab arm, which was on par with IFL plus bevacizumab in the first 300 patients randomized. Fluoropyrimidines plus bevacizumab are very active treatment approaches, and we have data from the prospective AVEX study, a study conducted in the UK, in elderly patients, capecitabine plus minus bevacizumab, and we know the addition of bevacizumab to capecitabine as a fluoropyrimidine had tremendous activity in terms of delaying tumor progression, highly statistically significant PFS results. So fluoropyrimidine bevacizumab, if we really want to use a maintenance therapy, is probably the best way to conduct maintenance therapy. This is not reflected in the meta-analysis published just recently. We have data, though, with actually two nice studies, the CAIRO-3 study, which Howard already presented, and the AO study, which looked at a capecitabine bevacizumab or fluoropyrimidine bevacizumab maintenance therapy and its value in first-line treatment. And you already saw the data of the design of CAIRO-3, which had, as a strategy trial, kind of various endpoints. And however you slice and dice it, the study was positive for its primary and important secondary endpoints, and the effect of maintenance therapy versus no treatment is best illustrated by this curve, and we all would agree that there is a difference. Maintenance therapy is able to delay tumor progression. There's no doubt about that with a rationally designed maintenance therapy of a fluoropyrimidine, here capecitabine plus bevacizumab. Quality of life in CAIRO-3 was maintained, so the use of maintenance therapy has no detrimental effect on quality of life, which I think is important. And the AAO trial, just looking at the maintenance therapy with fluoropyrimidine bev versus no maintenance therapy, had exactly the same results, hazard ratios in the same range as CAIRO-3. So we have data on fluoropyrimidine bevacizumab maintenance therapy, and there are other studies that have been conducted looking at the maintenance therapy, including the DREAM study, which looked at a different approach, bevacizumab as control arm versus bevacizumab erlotinib. And this is actually interesting because we have one maintenance therapy trial that has overall survival benefit. I still don't know exactly how to wrap my head around this because I don't know the interaction between bevacizumab and erlotinib. There's some data in non-small cell lung cancer, in EGF receptor mutated tumors that would support this, but we still don't know exactly how this would play a role in colorectal cancer. So the case for maintenance therapy, it's clear evidence that tumor control is prolonged when we use maintenance therapy in first-line treatment. And I think a VEGF inhibitor plus a fluoropyrimidine has a very good preclinical and clinical rationale and it's very limited side effects. Maintenance strategies, I think, are mandatory when we use an oxaliplatin-based first-line therapy to mitigate toxicities as component of upfront therapy. But I also believe maintenance therapy settings can be used to develop drugs. And this is actually being used right now, number one, in the FOCUS-4 trial, a very elegant trial, which you all know randomizes patients in a maintenance therapy setting in terms of drug development and maintenance therapy. Very attractive platform to develop agents. And the same is true for the so-called MODULE trial, which is a Roche-sponsored trial, which is governed by an academic steering committee, where also the maintenance therapy phase is being used for drug development, so very attractive. So this is a slide I kind of borrowed from Alberto Sobrero via Eric von Kutzen, actually. And I think, maintenance therapy is part of our treatment algorithm, treatment strategy that can prolong survival for patients. It's not this one breakthrough event that really changed the landscape in colorectal cancer. It's the addition of a lot of rational uses of sequential approaches. And maintenance therapy in first line is one of the components that I think is crucial to prolong patients' life, maintaining quality of life, using the least amount of treatment necessary to control the disease. Thank you very much.